So my talk will be on female sexual functions, and I have to disclose at first that I'm not an expert on that subject, but I hopefully through the lecture, the readings I did in the last few days, I'll be able to give a bit of an overview to better understand it, and as well to understand the impacts that our treatment, surgeries, and patients may have on their sexual function. The objective were sent. Initially, I wanted to spend some time about bladder cancer in female, but also in terms of surgical consideration. But I will want to spend more time on summarizing female sexual functions and the treatment strategies. So this will be the plan. And I want to put a bit of attention on the fact that last year, Anna Black did quite great grand rounds on female cystectomy and organ sparing and nerve sparing surgeries. So I will not go in details for those results because it has been covered already. And I will refer you to the YouTube video for hers if you're interested in hearing about a bit more about that. So if we start talking about bladder cancer in female, as you know, the incidence is quite lower than in male. So about a quarter of new diagnosis of bladder cancer will be in female, but the mortality is quite higher for female. Here, as you can see on that here, 5-year relative survival rates. On this here, you can see that the female per stage it has a lower survival rate. Another study looking in the Netherlands, over 24,000 cystectomy patients were looked at their survival rates, and as we can see here, they looked at the 10 years relative survival rates, but we can see that really by 2 years is where we can see a difference in terms of reduced survival. That red line here is for female, and the black is for male, and the blue line is actually the female survival rates, but standardized for some prognostic factors that we know, so age, TNM, and histology. So even despite standardizing for those factors, we can see that there is a 1.5 increase risk of mortality by 2 years, but then that difference is not seen following the 2 years. Some reason that could be some hypothesis in terms of reason for that difference. The biology of the cancer could potentially be better studied. Some will have postulate, that there might be a stage migration by the fact that female initially are delayed in terms of referral or investigation. So always something to importantly keep in mind when we see a female with gross hematuria, to investigate them and not treat 2 or 3 UTIs. Other important things to consider while treating female cystectomy or female bladder cancer is that they are having an increased number of perioperative complications. A tiny view here, but I highlighted what significant difference were noted. So that was an American study, of course, but we can see that readmission rates were higher, as well as superficial surgical site infection and transfusion rates were higher, significantly higher for female patients compared to male. So simply things to keep in mind as we give, have that preoperative consent with the patients in terms of what to expect. Something else also important to discuss and disclose to our patient is the vaginal complication, and also to keep in mind and in consideration when we're going to decide whether or not we do a vaginal preservation. So this study looked at the Marie-Pier data set and the use of 5% sample. So that was 480 female had cystectomy, and they reported a 2 years risk of complications of any vaginal complication to be as high as 20%. So 1 female out of 5 will have some sort of vaginal complication. More often it was a vaginal cuff dehiscence, as you can see here on that black line, but other complications are vaginal prolapse, fistula, dyspareunia, or evisceration. So things important, to again keep in mind, and especially that 5% of those, are, of the 480 patients had a reintervention due to those complications. Looking at the cystectomy, again, like I said, I will not go in details of how to do the surgery, but if we open your textbook, your Campbell, even the latest version will say that the anterior pelvic exenteration is the gold standard, and that will include removing the bladder, the urethra, the intervaginal wall, uterus, cervix, fallopian tubes, and ovaries. However, looking at the American guidelines, the updated version of 2020, it says that, you know, we should consider removal of those adjacent gynecologic organs, but that we should have the discussions to do organ sparing in patients who had organ-confined disease. However, what is an organ-confined disease? How do we clinically adequately stage it is another discussion, actually, where data is lacking, because we are used to do a bimanual examination under general anesthesia and use a CT scan, but, you know, as you can expect, this is usually not enough to adequately stage. How often is those pelvic organ invade is actually an interesting question, because if we were to remove all of those pelvic organs in every patient, we might be over-treating a lot of those. So this study published in this year was doing a quite comprehensive review of female cystectomy. So it was a retrospective review of women who had cystectomy from Mayo Clinic in Toronto from 1980 to 2018. So of course, there's a wide diversity of patients. Most of them did not receive any neoadjuvant chemo. But either way, that was 1,300 female cystectomy that were locally reviewed the pathology. And there was in total only 70 specimen that had a gynecologic pelvic organ that was invade, so making it a T4A, and 83 were PT3B. So they looked on those pelvic organ involvement, what organ was invaded, and most often it was the vagina, and then other organs here, as you can see, uterus, cervix, fallopian tubes, and ovaries. As I said it just before, the staging preoperatively is not often adequate or accurate. Sorry, so the accuracy of the pre-op staging to identify a T4A was only 26%, and actually almost half of the clinical T3 were upstaged to a PT4A. So really, we're not perfect at identifying pelvic organ involvement. So of course, it is difficult to say I will spare those organs if I'm not being able to anticipate it. But there's also, you know, consideration during surgery can be done. One thought, of course, is how can we improve, and can we use the MRI? In that study, which, as I said, looked up to 2018 in Mayo Clinic in Toronto, there was only 4 patients who had an MRI. Interestingly, they were all accurate staging. There's no specific study that looked at MRI in order to do a pre-op staging to plan for the surgery. But that could be something interesting. When you think of a radical prostatectomy, we have that MRI that will help us find if there are pylorus lesions on the right or left, and maybe consider doing a unilateral or bilateral nerve sparing. So this is maybe, you know, something that we should look for or study better. Something else here as well I want you to pay attention on is the ovary involvement. In that 70 patients who had pelvic organ involvement, there were only 7, so 12% had ovarian involvement. But if we look up on all their cohort, that was 0.05% of female who had ovarian involvement. So really keep that in mind, as I will talk about ovariectomy in a second. Finally, again, on that study, the last thing interesting to look up is that, you know, intervaginal wall was the most often common pelvic organ to be invaded. However, this isolated involvement behave in terms of cancer-specific survival in a similar way than a T3B. So here, as you can see on the red, is a T4A with only vaginal involvement, and the survival, cancer-specific survival, was quite comparable to a T3B. So they postulate, or, you know, at least brought into questioning, should we reclassify those and maybe consider that those patients who had only intervaginal wall involvement be treated or considered as a T3B. In terms of how to proceed with the surgery, I'm not going to go in details, but I think it is important that we have that conversation and offer this organ sparing and nerve sparing, and at least offer it to patient, or explain if this is something possible for them or not. There's interesting articles that we can read in terms of how to proceed. However, there is not that much data. There is no RCT comparing a non-nerve sparing to a nerve sparing approach in terms of outcomes. So more prospective or retrospective cohorts can be looked. Overall, if we summarize the outcomes, for example, in that systemic review here, we can see that the oncologic outcomes appear to be comparable, but there will be, of course, an improvement in sexual function. And again, for more information, I will refer you to Anna Black Grand Rounds. Ovarectomy now. So a quick note on ovaries. As I said, it is quite rarely invaded by bladder cancer. So really doing a prophylactic ovarectomy should not be done. And some of the reasons are the following. First, we know that it is detrimental to remove ovaries in patients. Quite convincing evidence from that Nurse Health study, which had over, I think, 45,000, but or 35,000, sorry, female had hysterectomy for benign disease, and they look at 20 years follow-up, and actually there was an increase in mortality rate of those who had bilateral ovarectomy as a prophylactic to prevent ovarian cancer. The number needed to harm was 8, so quite convincing not to perform that. Of course, that cohort of patients were younger female, more around their 40 years, who had, a longer survival rate. But still, it tells us that there's no reason to do it prophylactically. Other things that we know is that surgical menopause will increase cardiovascular risk as well as osteoporosis and impact on sexual dysfunction. Reason are that testosterone is still produced by ovaries, and that even after the menopause, in natural menopause. So if we surgically remove the ovaries, we will impair that production. And finally, if we look at American College of OBGYN, they will advocate not to do a prophylactic ovarectomy, but what they call an opportunistic salpingectomy. And things important here to see, and I was surprised to see that it's not every urologist who's aware, but doing a salpingectomy alone can reduce the risk of ovarian cancer. So this is something that can be offered. Again, those information come from gynecology, gyneco-oncology literature, which has a different population and age group of patients. But doing a salpingectomy during a time of cystectomy is not so complicated and does not really add more time. So this is something that we could incorporate. So this was what I wanted to review on bladder cancer. I wanted to, as I said, spend more time to discuss female sexual function and dysfunction, and hopefully understand a bit better, because I feel as urologists, we are lacking that training or that basic knowledge. And we are dealing with a lot of patients, like Dr. Black said, that we're going to do some pelvic surgery, but also some patients who might be in that menopause age who have other symptoms related to that, such as recurrent UTI, or LUTS or OAB, and I think it's important that we become familiar with it. This interesting study looked at the provider counseling and how they feel, how often they will have that conversation before radical cystectomy. So it was there was a questionnaire that was sent to a urologist in USA. So there was a part of the SUO members. 140 urologists responded. And here in this graph, to understand it, it's the rate of provider who do not routinely have a counseling with their patient before, during a radical cystectomy, and it is rated by the color per gender. So we can see that quite often provider urologists do not even ask the patient what are their sexual orientation, and when it comes with the baseline sexual function or dysfunction. Quite more often, female will not be asked at the baseline if they had any sexual dysfunction. Partners' sexual dysfunction is also something important to question, and is not often done. Other difference significantly is explaining and pre-op what will be the post-op sexual dysfunction that can be caused by a radical cystectomy, and options of referral and options of potential nerve-sparing approach is significantly less often discussed with female patients. In the post-op settings, there is, again, significantly less often female who are having that conversation of what are the dysfunction and what are their current sexual health. And referral options here, as we can see, quite too significantly, I will say, is not discussed with both genders. On the patient perspective, so this is one study only. It's not the best one, but it's, I think, interesting simply to see what are patients' perspectives. 1 out of 5 reported not to be having an appropriate counseling of the impact of radical cystectomy on their sexual function. They also reported some specific change following cystectomy. As you can see here, sexual pain with activity has been reported, change in desire, dryness, inability to have a sexual activity, or change in sensation. So those are a few things, for example, to keep in mind. That patient might, want to have gain more information to be prepared for the surgery, but also to discuss following it. More precisely, what can we tell our patient to expect? There's few studies that reported, the amount percentage of sexual dysfunction following radical cystectomy. I didn't put them all. So here is this study by ZIP, which looked at a prospective cohort of female. So they looked at their baseline and following the surgery, and they were all sexually active female. So if we look at their number, we can see down there first that over 50% of female who were preoperatively sexually active will have a decrease in their overall satisfaction following the surgery. And most will have a non-ability to have a vaginal intercourse and other impacts. So it's not only the length of the vagina that will be impaired, but orgasm will be impaired, as well as lubrication, desire, or pain. So a few things here to keep in mind and to disclose to the patient before the surgery. Now that we've looked at that, let's dig in a little bit more about how sexual function and response work. I will try to make it easy, or as easy as possible to understand, but this is quite more, complicated sexual response, and there is way more depth into than what I will simply present. But hopefully that will give us a bit of an information and understanding of what and how is the sexual response. There is different phase. First, I put desire and arousal. So desire was some will thought was always needed before, but actually the desire could be a part of the arousal phase before or while. So really, if we talk about the arousal phase, we will note that this phase is characterized by an increased engorgement in the clitoris and the vagina. We will see an elongation of the vagina. Some other increase in genital sensation will be noted. We will have an increase of tachycardic response or nipple erection. This phase of excitement will lead to a plateau, which is really that phase that is simply of excitement that is prolonged. And then in female, there could be some orgasm, so singular or plural, so female could have more than one. And an orgasm is described as being a variable but peak sensation of intense pleasure, and that will lead to some rhythmic and involuntary contraction of some of the pelvic floor muscles, levator ani, as well as vagina and anus. This phase, this orgasm will release oxytocin hormones, and then the resolution phase will come, which the resolution phase is, coming back to that baseline level. The oxytocin hormones will play a role in that sensation of pleasure that will follow it in that relaxation phase. So in the resolution in that oxytocin hormones, we'll see back to a normal, but some relaxation, and also some feeling of wellness. And we can see that it can increase and provoke some endocrines and impact, as well as feeling of self, for example, contentment. It can also have some benefit in the couple, for example, increasing the bonding via this hormone. the cycle or the sexual response in male or female overall can be described by different model. Here by Dr. Bazin, we'll see that it can be described as a motivation-led or incitative. So the sexual response can be initiated by firstly a motivation. The motivation to engage or to have a sexual activity can be multiple. It could be either emotional. So if, with a partner and love will provoke or be a motivation for the sexual activity. It can also be physical. So wanting of pleasure, or it could be for stress release, for example. It could also be a goal attainment, so some social status, for example, or could be considered as a motivation, or insecurity. In part of insecurity can be a feeling of duty, or to increase, like I said, self-esteem, for example. So those are examples of motivation. Then the sexual stimuli that is required. Sexual stimuli is not only physical or tactile. It could be any sense that can be stimulated. So it could be visual, so sexual, seeing something sexual, or it could be verbal, hearing some erotic talk, or that brings some sexual memory, for example. It could also, of course, be sexual, and that could be towards genitalia or not, or other organs. And if looking at genitalia, it can also be penetrative or non-penetrative. So that sexual stimuli alone is not enough. It requires as well a context. And the context is multiple, but for example, it could be the lack of undue fatigue. Or a context that is processed as being safe, or with privacy. For example, if you have your kids around, your sexual stimuli will not have that same impact if you are not processing that as being something with privacy. So the context is important, and as I just said, this stimuli will be appraised. So there is a process of appraisal and cognition. There is some reflective integration, but there is still some conscious appraisal that can be impacted by some psychological factor and biological. And whether or not this will be processed as something that can move on will be part of the cognition. For example, like I said, if the context is not propice, or also if there's some pain that is provoked by that sexual stimuli, that will not lead to that sexual response, and that cognition can regress the response. Interestingly, one study looked at the appraisal in female, for example, of the engorgement in the genitalia. So a study looking at the female with hypodesire disorder compared to control, so a female who did not have any hypodesire disorder, looked at with using plethysmography of the genitalia engorgement after a sexual stimuli. And they actually noted that on the genitalia, the engorgement was similar in both patients, so those with a hypodesire disorder and those who did not. However, subjectively, patients who had the hypodesire disorder reported or subjectively believed that there was a reduced arousal. So that appraisal cognition was different, despite the fact that maybe objectively there was no difference. So showing a quite important part of the cognition and potentially psychological factor. And that can be seen as a difference compared, for example, of male. And that's when you think of phosphodiesterase inhibitors, for example, in a male, if they have a soft, erections, and we give them some medication and the erection is improved, then visually they will see that, and that may boost their self-esteem, for example, which could lead to a better appraisal and cognition and a better sexual response. However, in a female, improving that engorgement may not have that same positive impact and may not actually improve the sexual response. More clinically, in terms of what happened in the organs. So the clitoral complex, as you might know, it comprises the clitoris, the distal vagina, and also the urethra. So here I want you to pay attention of the urethra being quite surrounded by the clitoral complex and erectile tissue. It is important to keep that in mind as we will be often doing surgery near this organ. The urethra plays a role for the sexual function, but also for a protective function. So for sexual, as I said here, for erectile tissue, but also it will lubricate. There's some skin glands that are near there that will produce some lubrication during the phase of arousal, but also it's protective by that valve effect of closing the urethra or increasing the pressure that would prevent injury or from to the bladder, for example, for infection. More in details in terms of nerves and what is the response we can see. There is a reflex arc. So the sensory receptor of the clitoral complex and the vulva, from a tactile sensation, will go through somatic afferents of the pudendal nerves, so the dorsal clitoral nerve and some perineal branch that comes from the pudendal nerves. They will go to the S2, S3, and S4 in the spinal cord. And a visceral response, or visceral efferents, will come via the pelvic parasympathetic fibers, so the pelvic nerves. And that response, that effectors will be the erectile and spongy tissue that we just saw on the slide before, part of the clitoral complex. And there's also a secretory response, which increases the lubrication. So engorgement and lubrication as part of the arousal phase. And that comes from the subulbar and urethral glands. Sorry. More details in this photo, I think here, and this, illustrations, we can see nicely the interaction and the proximity of those nerves to the organs we'll be doing surgery on. So I talked about the pudendal nerve here that run along and will cross, really over laterally on the urethra. And that will be important for the somatic sensation of the clitoris. And that will have its role also of response of contracting perineal muscle to maintain erection, and also those rhythmic contractions of pelvic floor levatorani at the phase of orgasm. So this here, as you can see, as you can imagine, can be injured at time of a uretrectomy. Other important nerve, as I said, is the pelvic nerve, that parasympathetic response that runs along the vagina here. There's some branch that will go to the bladder for the bladder function, but then this cavernous nerve that will be on the intervaginal wall that again can be injured. The nerve, as I said, is responsible for some of that arousal phase, for sensitivity of the genitalia. They will also have a role to increase the blood flow from that erectile tissue, and the lubrication of the vagina. So the vagina is lubricated via a transudation process. And finally, it also plays a role in the orgasm rhythmic contraction. Finally, blood supply, always important. So brief review, you know your anatomy, but I wanted you to see, so branches of the internal pudendal will have the dorsal clitoral artery. I hope you see my mouse, but here, as you can see, will cross over at the bladder, urethra, sorry. So can be again injured at time of our surgery. The external pudendal artery coming from the femora will have a small contribution, but more on the skin that covers the clitoris, so not so much for the sensation of the erectile complex. Finally, if we go again more in one more depth of layers, the arteric tone, so the blood vessel tones at basal conditions, similarly than in the man, will have a high tone, which is mediated through sympathetic activity, so reduced blood flow. During arousal, and there will be VIP non-peptide hormones that will be produced that will cause a dilatation of the arterial supply, and also the nitric oxide that will promote relaxation of sumo muscle in the cavernous sinus, will increase the engorgement. And interestingly, testosterone will play a role by being what we call a permitting factor for endomediate vasodilatation, and estrogens will play a permitting role for the VIP vasodilatation, and estrogens also are important for vaginal lubrication as well. So that was a bit of a more in details of what is the response, and more specifically female sexual response. If we start talking about female sexual dysfunctions, before going into more details of our cystectomy, just an overview that in general, female who have sexual dysfunction will have overall similar disease or risk factor than male who has erectile dysfunction. So risk factors are aging, hypertension, smoking, depression, and pelvic surgery, of course. Here on this drawing, we can see some of the types of female sexual dysfunction, looking at what the DSM-5 has classified. So we can have a disorder of orgasm, as definition will say, marked delay in frequency or absence of orgasm. There's also the female sexual interest and arousal disorder, which is described as being at least 3 of those symptoms, but basically it's reduced or absence of interest, fantasy, or initiation or receptions to a partner initiation, or a reduced or absence pleasure or a sensation or arousal. So it's really questions of interest and arousal here. And then finally, there's that pain or genitopelvic pain or penetrative disorder, which the name kind of tells you what it is, but it can also be a pain or fear of intercourse. Finally, there's always, that other category or unspecified or substance or medically induced. Now that we've looked in terms of, what is the female sexual response, I think we can now better understand what is the impact of cystectomy that can have on the sexual function. So I put here just, so we can better categorize it or simply visualize what impact we can have. So anatomical impact from cystectomy. If we do intervaginal wall resection or pelvic organ removal, we can see that there could be a reduced length that can lead to dyspareunia, or can totally prevent any penetrative intercourse. There's also risk of prolapse, as we said, some of the complications that can happen by doing or removing pelvic organs. There's also some change from scar or stoma that can have an impact on body appearance and self-esteem. That can have an impact on the cognition of the sexual response. There is also some hormonal, potentially, if we do surgical menopause or remove ovaries in the menopausal female, that can remove the testosterone. There is some nociceptive potential impact if we injured pudendal nerve, as we've seen at the time of a uretrectomy, or the pudendal or pelvic complex as well play a role in the autonomic response, which can lead to reduced lubrifications as well, or sensation. And finally, devascularization. So if we injure that clitoral artery or branch of the internal pudendal, that can devasculate the clitoris, which can lead to fibrous change, which will reduce sensation, can reduce or impair lubrification, for example, of the other organs, and lead to an orgasm. Sorry. The sexual dysfunction can be represented again with different model. Here, I wanted to present this one because I thought it was quite interesting, and then understanding really that there is a lot of things and factors that plays a role in sexuality. So this model is presented by Lindo. So it's looking at biopsycho and social factors, and is as we can see around the sexuality, there is different factors such as opportunity, attitude and interest, and capacity and function. We can see that there's our patient, but there's also the partner. If we started looking at our patients and the impact of cancer, for example, some psychologic, psycho or cognitive impacts, such as a change of body appearance, having a stoma, or other symptoms such as depression or anxiety coming from the diagnosis of a cancer or fear of recurrence of the cancer, can have an impact on the attitude or the interest into sexuality. There's some evident, physical change, as we talked about, reduce, for example, like length of vagina, or some dryness that can lead to dyspareunia. That will impact the capacity or the function. Finally, some social aspects are important. For example, and that comes with the relation with the partner. For if the conversation always turn around the cancer, that may reduce the opportunity or the into that intimacy or desire of sexual intimacy. The partner is also important to be taken into consideration if him or herself have some issue already, as reported here, that can have an impact also on the patient. And those factors, such as, for example, fear of causing pain to the partner or erectile dysfunction, those things are important to take into consideration when we treat a couple experiencing some sexual dysfunction. As you can imagine here, looking at all of those factors alone, a urologist will not be able, or I don't know about you, but I will not be able to address all of those things. So it's really important to approach it with a multidisciplinary approach. So this brings me, to what are those treatment strategies, and having an approach that involves multiple people and multiple techniques is important, and to be centered around our patient. So I will hopefully make it on time to review those strategy options. As a surgeon, things that we can consider, offering a nerve sparing. I think you understand now the reason why. Doing an organ sparing as well. I think the point has been made. And preservation of the urethra. If there is no involvement of the bladder neck or any concern for involvement of the urethra, preserving the urethra will have a better sexual function following the surgery. Finally, offering a vaginal reconstruction usually involve a second surgical team, so it's not often offered, but this is something that to keep in mind if a patient is wanting it. But I will not go into details too much about how it can be performed. Just for your information, some myocutaneous flap can be used. Intestinal, not so much because of the amount of mucus, and some mesh have been reported. So this is in that publication of Davis, if you are interested in reading about it. So it's SurgiMed mesh and lamentine flap that was described. As a surgeon and as a physician treating those patients, I think there's a big part that is important, which is communication and counseling to our patient. I thought interesting to bring up that studies have proven that cancer patients are unlikely to initiate that conversation about sexual function. So we have to keep that in mind and be the one to bring that conversation. Some barriers have been identified from a patient point of view, often some mismatch in terms of expectation, or the patient having fear of making the provider be uncomfortable or believe that the sexual function is less important, or lack of confidence to address those issues, or also the perception that nothing can be done about it. From the provider point of view, barriers that have been noted is a lack of training. So this is, unfortunate. We could try to improve that, or having a limited time to discuss those things, or fear or concern of making the other uncomfortable, or uncertainty of how to manage those. So here again, a better education or training of our of urologists can be improved. In that preoperative discussion, I think it is important that we proactively seek what is the patient's baseline sexual functions. Do they already have some dysfunction? Do they have a specific concern? And also, what is the importance of their sexual function as we talk about oncological surgery? It's also important to include the partner in that conversation. And really here, I think there's nothing really extraordinary that I brought when you look at what we do for a patient with prostate cancer. So it's simply a question of doing it for female as well. There is an importance of preoperative education to the patient in terms of what are the side effects. And I think having a realistic expectation of how often some of the side effects or impact on sexual function will help the patient to be prepared for it. Some of the domains of questions we can ask our patients, for example, talking about sexual function with a female, male as well, is the desire, the arousal, sensation, lubrication, orgasm, pain, and overall satisfaction. So those are a few things that can be discussed if we want to go more in details. Also important to have that conversation after the surgery. There is no proper guidelines in terms of how we should do. There is not so much literature as well, but it will be a rule of thumb of saying that at 3 months we assess how the patient is, as well as the follow-up up to a year at least. What to expect is a bit difficult to have good hard evidence of what is the usual recovery. We can use some of the gynecology literature since they have more data on it. Coming from hysterectomy performed for a cancer, we can see that most females still had dyspareunia by 3 months. Impaired orgasm will be noted up to 6 months, and interest and frequency in sexual activity can take up to a year before improving. So giving a bit of those, timeline of what to expect can help the patient being prepared. Questionnaires, few questionnaires exist. If you are interested to downloading them, I think this one, it has like 19 questions, so it's a bit long, but in clinical trials as often being used. There's more, of course, and all have their own issues. Here, if you are interested in something quite easy, it's called the 5 A's. So simply asking the patient, advising or reassuring about the problems that it can be addressed, assessing for some specific symptoms, such as doing, like the checklist, for example, and then assisting the patients, in terms of what resources or referral and arranging a follow-up. Now that we looked at some of the surgical point of view, psychological impact is important, and offering couple counseling and sexual therapists is really important. They will have that ability to spend time to see all of those factors that are important to the cognition and the process of the sexual response. It's also important to identify some depressive or anxiety symptoms, since they can have an impact on the sexual response. And here we can decide to ask for a GP to intervene, for example. Overall, there is a high efficacy and really no contraindication to refer for counseling. So really, there is no reason not to refer. Other non-pharmacological tools, making sure we have a good sleep, exercise, and healthy diet, and avoiding alcohol or chemical use, always a first step important. More precisely to our patient, vaginal moisturizer, since lack of lubrication can be seen by menopause, but also by our surgery. So moisturizer is important. Vaginal laser, there's some new studies, but nothing on radical cystectomy, and honestly, data is not so clear. Intervaginal wall reconstruction will require dilatation, so things to bring to discuss. Here, quickly, I wrote pelvic floor physiotherapy. It is something to keep in mind, super important for all of those who has pelvic tone increase that can lead to pain, or that is with dyspareunia. So referral for pelvic floor physiotherapy will be important. And the use of sexual stimulation device, this can be discussed with the sexual therapist, but it can also be brought to the conversation by the physician or the urologist. I thought that article interesting. So it's a clinical reference of sexual devices, that literature from OBGYN, but it was interesting to have that medical descriptions of all of the different devices that exist. And the rationale is that during the surgery that we do, we might impair nerves or vascularization that can lead to a reduced response of arousal by the stimulation. So increasing that stimulation can lead to maybe better arousal phase or orgasm. So they can really play a role in improving the female dysfunction. And finally, last slides are on pharmacology. The things that you need to understand at firstly is that there's nothing really that have been studied in post-radical cystectomy women. So sadly, there's really a lack of literature in there, and hopefully this will change in the coming years. So what I will review here are those treatments that have been looked or studied or available for, in general, female sexual dysfunctions. So I will look up on those ones. Firstly, I wanted to do, quick notes, if I have time, about menopause. So a lot of our patients will be in that menopausal phase. And if I'm, getting out of that context of cystectomy or bladder cancer, it is important to be aware of the menopause and the impact of reduced level of estrogens in our patients. Overall, it is in their 50th year that the patient will have those systemic symptoms. But that transition phase of where the there's a cessation of mens will have a transition that can take up to 7 to 14 years. More early, we'll see the onset of the systemic symptoms such as hot flushes, night sweats, irritability. But we can see with a more delayed onset, those genitourinary syndromes of menopause, or called GSM, as well as the female sexual dysfunction or recurrent UTIs. So those can happen later on. The reduced level of estrogens have been shown to have those impacts. And when we talk about genitourinary syndromes of menopause, it includes atrophy. It includes also the lower urinary tract symptoms such as irritability or that kind of overactive bladder, but also some dyspareunia or dryness in that area. The treatment of menopause for those who have those bothering symptoms is via systemic hormone replacement treatment. It's oral or transdermal estrogens with progesterone if the patient has a uterus. And they have been, proven to improve menopausal symptoms, but also prevent osteoporosis. It is contraindicated in patients with breast cancer. However, the impact of the GSM is not so much present, but will be improved by local estrogen. A quick note for those who wonder how the safety of systemic hormone replacement therapy is. It comes from this article published in Nature Review, which clearly show here in blue that the life expectancy of female who had estrogen replacement was actually longer than those who did not. And that really comes by the fact that estrogen replacement therapy improve or reduce the risk of osteoporosis. So hip fracture is reduced, but also by being cardiovascular protection. In this article, that they showed that the improvement in the cardiovascular protection effect is better if the hormonal replacement is initiated within 6 years before within 6 years after the beginning of menopause. The neurocognitive protective effect and its timing is, however, less clear. So those systemic hormones treatment, as I said, will have beneficial impact on osteoporosis, cardiovascular, and some hot flushes symptoms. However, if we look more at the GSM symptoms, vaginal estrogens will be beneficial. Evidence is quite convincing in terms of the improvement, as we can see that in this Cochrane review. It is available and approved in Canada and USA to improve the genitourinary syndrome of menopause. So it is beneficial for sexual function, also for recurrent UTIs, and for some of the lower urinary tract symptoms. There is really a minimal risk. This, should be something that as urologists, we're dealing with a lot of those patients, we should be familiar and able to propose. Here are some of formularies if you are interested. There isn't really any, they're quite equivalent. So I think it's important I would just get familiar with one of those and offer it to our patient. Testosterone supplementation have been studied. It is not approved, but is something interesting, I think, to discuss. So the rationale behind it is that testosterone, as I showed you, promote the anal vasodilatation. Also, there seems to be an impact on patients with lowered sexual desire and arousal, and also on the well-being. However, things to keep in mind is that in female has natural menopause, the testosterone level in their body is actually the same before and after menopause. So it does not seem like there is a reduced testosterone level postmenopausal. However, important thing to keep in mind is that the surgical menopause will cause a lowering of the testosterone, since ovaries postmenopausal will still produce those testosterone level. So here again, something important to keep in mind for when it's not indicated to do an ovarectomy, to preserve those ovaries. This Cochrane review looked at studies that evaluated testosterone in postmenopausal women, either with natural or surgical menopause. They showed that the addition of testosterone to hormones replacement therapy improved the overall sexual function scores, only in postmenopause, so it was not for patients in peri or pre-menopause. Adverse effect to be aware is decrease in HDL cholesterol, empirical hair, and acne. However, despite that it seems to have evidence showing improve, it is not universally accepted. Some will have concern in the long-term risk, but also some will bring into questioning those studies, since they most often included patients who had reduced satisfactory sexual intercourse per month, but were not for patients with severe symptoms. So most of those patients had at least 2 or 3 activity per month, which is not that severe, which we can see in our patients. So we don't know for patients with more severe symptoms. The use is off-label, like I said, in USA and Canada. However, interestingly, in Europe, it has been approved for post-ovarectomy, as we know that surgical removal will impair testosterone production. Relative contraindication listed here, but absolute important to keep in mind is the breast cancer or endometrial cancer, DVT and PE, and cardiovascular disease. For the monitoring, annual breast and pelvic exam and mammography, as well as clinical evaluation of side effects. And it's recommended to do labs of SHBG as well as testosterone. There isn't, perfect guidelines in terms of what the level, but we should aim to not have values that goes above the normal. We should consider including lipid profile, liver enzymes, and CBC. Rule of thumb of stopping after 6 months. Quickly, so vaginal DHEA. So I've been studied as a local vaginal cream. It is approved in Canada, Health Canada, for vulvovaginal dyspareunia. So some studies showing improvement of multiple desire and arousal, but really was studied and approved for vulvovaginal atrophy. Long-term safety appeared to be reported with that study looking at 52 weeks, where there was no systemic absorption. The hormones level were similar. Ospinifen is an alternative as an oral tablet for, again, dyspareunia and vulvovaginal atrophy. It is a 3rd-generation SERM, so agonist effect of estrogen receptor in both vagina, bone, and introitus. It has not been studied in breast cancer, and again, not really in bladder cancer, but it is an alternative as an oral form. Now, non-hormonal, we have flibanserin. It is Health Canada and American FDA approved for female with hypoactive sexual desire disorder. So it's really the only one for that has been studied and approved. However, I have to say that the data showed some improvement of satisfying sexual event, but that was really an increase of 1.5 event per month. However, there was quite significant side effects to be aware, which were clinically and statistically significant. So dizziness, somnolence, nausea, and fatigue. I don't know if it's commonly used, but there is those side effects to be aware that are non-negligible. And finally, phosphodiesterase, so Cialis and Viagra. The results are quite inconsistent. Initially, I explained you that cognition response, that increased engorgement might not result in an improvement of sexual response. Some studies show no difference. Others reported an improvement for those who had arousal disorder, but actually in their study, they looked at those who had hyposexual desire did not have an improvement. So if they had desire impairment, but only arousal, the impact was not really there. So really the data is not so good. And side effects are the same that we know. Rushing to conclude, I wanted just to bring you the importance of referral in order, since we don't have that much literature in terms of medical treatment, but we do know multidisciplinary has a good impact and is important, and being aware of the local resources that we have here in Vancouver and BC, the Center of Sexual Medicine located in below the spinal cord. They have a form for referral. If you just Google that or look at this here, you will find their form on Google. So that concludes my presentation. Sorry for taking that much time. Briefly, bladder cancer, it is significant bad outcome oncologically in the first 2 years for females, so adequate treatment is important, and radical cystectomy do have an impact on sexual function, so it's important to have that conversation before and after in terms of what are the impact on the sexual function to our patient, and really keeping in mind that multidisciplinary approach, since the sexual response it is not only, needs to be addressed by multiple ways. Thank you.